Thank you very much indeed. I hope this is not as controversial as the the last talk. When I was training, birth asphyxia was a disaster. It was a devastating end to pregnancy, and we had absolutely no idea of how to prevent it or treat it. It comes often from a whole range of different etiologies. And the key event is the intrapartum hypoxia that occurs often due to obstetric accidents, or most commonly it is unexpected. The key observation that we made in the 70s was that you could actually look at babies and examine them and grade the encephalopathy. And if you graded the encephalopathy, you could determine the risk to the child. And this super study from Neil Feiner and Charlene Robertson actually has never really been bettered in the literature. It shows nicely that if you have mild encephalopathy, you usually escape without any significant impairment. If you have a severe encephalopathy, almost all babies will die, or they will have a serious impairment, a serious disability. And if you have a moderate encephalopathy, the answer is somewhere in between. And that would be fine, but they then went on to look at these children in middle childhood, and it's quite clear that this is not quite as easy as listing this as no disability, because children who are exposed to intrapartum hypoxia are at risk for later cognitive and learning difficulties, which may cause the child significant impairment in life. So this is an important issue that we need to address. Now, in my hospital, when I was training, I was taught by the guy standing up holding this card, Oz Reynolds, and he was the first person to be able to actually study the brain in vivo in the late 1970s, early 1980s, and he was the first person to describe that actually the brain recovered quickly after a hypoxic event and then subsequently became injured. And this has really been a seminal observation. And this is the very first, you can't really see it, I suspect, on this slide, but this is the very first spectra taken from a baby in the basement of the obstetric hospital in London. Now, they went on to study this in a large group of infants, and they used a phosphorus spectroscopy to study the appearance of these three peaks here, 5, 6, and 7, which are the three phosphorus peaks that identify the state of energy within cells. And you can see that this is taken 8 hours after birth, and you have what effectively looks like a normal profile. And then as time goes on, these three peaks all become smaller, indicating that cells are dying. And you can chart this on a graph, and you can relate the disappearance of these peaks to long-term outcome. And that, again, was a critical observation that allowed us to go forward. And as we know now, there is what we call a therapeutic window, which actually lasts for some ill-defined period after the insult. And if you can, if you have the initial insult, which is what they call primary energy failure, and then you have this recovery, and during this recovery, a whole series of cellular mechanisms occur, which then promote self-guided cellular death, what people call apoptosis. And they also links into the inflammatory cascade which goes along. And then you have this period of secondary energy failure. And if you can intervene in this period here, then it is likely you can prevent a lot of the injury that happens. This is often described using a graph like this, where you have primary cell death, a latent phase, and you have your hypoxic insult just before birth, and then the period of resuscitation. And actually understanding how to intervene in this latent phase has been really important. So we then started to search for interventions that might stop this process. And we understood fairly early on that you had to get in pretty quickly after birth. But actually there's a long history, and the history starts in Russia in many ways, where they started to cool infants after birth and claimed it was very good. But of course, in those days, they weren't doing randomized trials. And then in the 50s and 60s, people started to pay more attention to this. But in the early 90s, Mariana Torreson presented to a group of neonatologists called the European Neonatal Brain Club. And she suggested that we should actually look at hypothermia as a way of stopping this latent secondary energy failure. And she did studies, again, in the basement of University College Hospital with piglets, and demonstrated that hypothermia indeed did reverse many of these later inflammatory and apoptotic events. And since then we've had large trials, and we've had Cochrane reviews, and that is history. We now know that if you treat a child with hypothermia, that you actually stop a lot of this secondary energy failure. And if you do that, you can preserve the high energy phosphates, and you can also reduce the amount of acid, lactic acid, in the brain. And these are representative spectra, which I'm not going to take you through at the moment. So we then end up with the first 3 big trials, which all came from that original Neonatal Brain Club meeting. The CoolCab trial, the NICHD trial led by Sita Sankaram, and the UK TOBY trial. And if we look at survival without impairment, much as Dirk has shown, this favours hypothermia, and we know that we need to treat 8 babies to prevent 1 child dying or having disability. We also know that it seems to be more effective in those children that we're most interested in, those in the moderate encephalopathy group. And you can see here, I'm sorry, this is the other way round to the previous graph, but again, this favours hypothermia. And you can see that in severe encephalopathy, you actually have a non-significant effect. This is from the Cochrane review, which was picked up by Jacobs, and she has added in here, the smaller ICA trial, the Neo-N-Euro trial, which was run out of Austria, and the ICE study that was run out of Australia. And again, this actually favours hypothermia in all accounts. This is death or major disability. So we have this 2-phase neuronal injury, the acute hypoxic cell death, and then the programmed cell death, apoptosis. And we think that the interventions that we put in after birth will reduce apoptosis. But actually, of course, if you've had primary cell death, you're not going to recover from that. And so all of these trials actually reflect a balance between the hypoxia that is potentially resolvable and the hypoxia that has led to cell death in the first place. And so it is unlikely that any intervention is going to completely stop disability or death after acute intrapartum hypoxia. And of course, there is a second issue that we don't know in the human situation when the insult actually occurs. In the laboratory, it's very easy because you can take an experimental animal and you can expose them to a defined period of hypoxia, and then you can do your interventions and study it. But in the human situation, often the event may start sometime before delivery, and the child may already be in the phase of secondary energy failure when he's born. And so one has to remember that there is still a bad outcome at the end of these trials. Only 56% still had bad outcomes, but there was a significant reduction. And this shows you the 3 major trials, in red for the normothermic and blue for the cooled. And you can see that for each of these outcomes, there is a reduction after cooling, but that it doesn't go back to 0. So we need to move on from these trials and refine our care. And refining care after you've done a series of big trials is quite challenging because everyone thinks they can do it. And as we all know from our clinical experience, letting babies get cold is easy. So we have to choose which babies we select for cooling. And in the UK, we tend to do it in a 3-phase approach. In the United States, they only use the first 2 of these. But we need evidence of poor condition at birth, we need evidence of abnormal neurology, and we need evidence of EEG depression. Poor condition at birth, we have fairly strict criteria that you need to have a pH less than 7 or a significantly acidotic base deficit. You need to have evidence of a poor APGAR score of 5 minutes, or the need for ventilation in a term baby after birth. And you need to have identified a sentinel event, such as cord prolapse, such as an event on the cardiotocograph. In terms of abnormal neurology, there are a range of ways in you can do it. The first people to describe this were the husband and wife team, Sarnat and Sarnat, and they described a beautiful examination, which is actually quite difficult to do, but I still think is probably the best examination. But you do need training, and you need a lot of inter-observer validation before you do use it. Then Sita Shankaran has described a standardized examination, which in the States is now licensed and accredited, and people have to go through if they're going to cool babies. And then we tend to use a much more pragmatic score, which is derived from the Sarnat score, but looking at these 6 areas of functioning. And this was described in a seminal paper in 1997. And the nice thing about this is you can score it, and then you can follow the child's progress. And it is quite interesting that we've been able to show that hypothermia reduces the score beautifully. So, and that's associated with benefit. And then finally, we tend to use evidence of cerebral depression on EEG. We tend to use, these are very old amplified integrated, amplitude integrated EEGs, but I rather like them because it took me a lot of effort to get them in those days. And you have a normal trace where you've got a reasonably high baseline around 10 microvolts, and quite a narrow trace with evidence of variation. You have a moderately depressed amplified integrated EEG, which has the bottom end of the trace is below 5 microvolts. And here you can see a seizure happening, which actually projects this, the baseline and the whole trace upwards. And here you have a very narrow and very low amplitude tracing, which is a severe depression with intermittent seizures sitting on top of it. This is very easy to use, it's very straightforward, and actually it's a very good way of defining what's happening with the baby. So That's fine. So who to cool? What dilemmas do we have around this? Well, the first thing is we must remember that cooling is really only applicable to term babies in terms of the studies and the evidence that we have. And it's really 36 weeks onwards that we should use it for, and we shouldn't be using it for more preterm children. There's also a lot of interest in the later cognitive problems that we see following the moderate and mild encephalopathies. And maybe we should be cooling children with mild encephalopathy, which we don't tend to do these days. But we need evidence for that, and there isn't really evidence out there. And as I'm going on to describe, I think cooling is an intensive care intervention, so we need to be careful who we apply it to. We also need to be sure that we're not just using seizures as an entry criterion, because seizures come from many other causes. And must not forget that seizures come from meningitis, they come from inborn errors of metabolism, and we need to distinguish these before we embark upon a period of cooling. We also worked really hard to get babies into trials before 6 hours of age. And really the evidence that we have only applies to babies who have cooled within the first 6 hours after birth. And since the trials, we have started cooling immediately. We've recognized the child has an encephalopathy. But we don't know whether later cooling is actually valuable. And the other group that we look to cool are babies who have sudden unexplained collapses on the postnatal wards. And we've had some, I think, fairly successful case reports of this, but of course the numbers are too few really to be able to draw firm conclusions. So I think one of the things messages I want to get through today is the fact that we need to make our hypothermic rescue the best it can be. And we can do that in all sorts of ways. I then want to go on to talk about the adjunct treatments that we're now beginning to add into hypothermia to try and reduce that number needed to treat, and some new approaches that we're taking towards it. So, should we start earlier? Should we continue? Should we start later? Should we cool to a different temperature? We seem to have stumbled on cooling to 33.5 degrees centigrade. Is cooler better? Is warmer better? Should we continue for the full 72 hours, or is shorter or longer cooling worth doing? And what about rewarming? What about sedation during cooling? And what about how should we treat seizures in this situation? And should we be cooling babies in all settings? And we'll come on to that in a second. So starting cooling is actually very easy, but we have to remember that not all babies in poor condition at birth have encephalopathy. And so I really am not overly enthusiastic about switching the heaters off in the delivery room until we're absolutely sure that's what we're dealing with. And we've had one or two classic situations where we've been cooling babies. It's become apparent that they have something else wrong with them. Sick babies do lose heat rapidly. And right in the 1950s, the phenomenon of auto-cooling was described. And here is a lovely study which was done by my colleague, Nikki Robertson, in Uganda, where they wanted to cool babies because in the third world, asphyxia is a major cause of death and probably responsible for about a third of neonatal deaths worldwide, and there are 4 million neonatal deaths. And so she developed a very simple cooling strategy. This is the result of her cooling strategy from birth. And you can see here that she was very good at using actually water at 26 degrees in what we would call a hot water bottle at home in the cot to do this. But interestingly, the standard care group also were cold to start with. And they took actually around 20 hours to warm up to become normothermic. And it's thought this is an automatic physiological response to asphyxia, which actually helps to protect the brain in its own way. So I think we need to just remember that the baby can often tell us what's going on. I think it's also critical that we avoid overcooling or overwarming during hypothermia, and that's something that has been trialed recently. Best of all is to use one of the servo-controlled devices, and you can get a very nice rapid induction phase over 30 minutes to bring the child's temperature down, and then maintain it, and the maintenance of hypothermia at the target temperature is really important over that period. And then you have this rewarming phase, and we rewarm at only half a degree an hour, which is very easy to do on a servo-controlled event. And you do get often problems during this period, which you will need to take action on. So it's not a simple intervention. So Sita Shankaran led a further trial in North America where they wanted to study longer and deeper cooling. So they developed a factorial trial where they had 4 groups, where they were cooled to 33 degrees for 72 hours, or 32 degrees for 72 hours, or 33.5 degrees for 120 hours, or 32 for 120 hours. And the problem with this study is it was stopped early for various reasons, because these 32 degrees and the prolonged cooling arms had longer, had increased mortality. And it seems that we appear to have got it right with our first guess with hypothermia. The other thing is that they managed to institute cooling much more rapidly than other trials, and that's been really helpful in telling us what to do. So the risk differences are here. Whoops, there we go. So the servo-control devices are very valuable, and we use the Tecotherm Neo, which is something which we developed in liaison with industry. And the great thing about it is you can put it onto your transport incubator, and you can cool babies during transport, because you can't get, these babies are born all over the place, and they're not necessarily born in the centre with an NICU, as you well know. We found this really very, very easy to use. During the rewarming phase, you may suddenly find the child has seizures. And one of the critical things that we've identified is that actually seizures with asphyxia are much less frequent when you're treating babies with hypothermia. So actually, it's a better anticonvulsant than most of the drugs that we use to treat seizures following hypoxia. We have actually slowed down our rewarming because we found that on occasions we had all these seizures that occurred during the rewarming phase. So this is the cooling phase, rewarming, normothermia. And we also observed that if we see seizures as babies are being rewarmed, we recool them for a further 24 hours, and the seizures tend to stop. The next thing is, how do we manage babies when they're being cooled? It is really important that we take steps to reduce any pain or stress during the process. It's very uncomfortable to be shivering and cold. And Mariana Torreson has used her laboratory studies and shown that if you, during these phases, if you don't treat children, or animals in this case, with sedatives, that actually the benefits of hypothermia don't exist. You can see here, these are unsedated animals. And actually the brain, the pathology score in the brain is the same whether you're cooled or not cooled. So you do need to think about this, and this is the cortisol level during cooling, which goes up quite dramatically. At my hospital, we actually routinely intubate and ventilate during cooling, but that's not, I don't think, necessary. It's something that we have done for many years, and we're very comfortable doing it. And that allows us to use high-dose morphine during the intensive care period. And lots of my colleagues will use lower doses of morphine with an awake and spontaneously breathing child. We also use muscle relaxants during that time to actually stop shivering and monitor the EEG constantly during the period of hypothermia. We need to make sure that we monitor effectively for seizures. And I had not realized that actually the number of seizures that we see clinically is only the tip of the iceberg. And many of the seizures that we see on EEG are completely unrecognized clinically. You can see here that 91% in this study from Cork of seizures were actually unrecognized during video EEG. So when they were looking for them, they had the EEG next to it, they could not see any clinical manifestation of seizures. So we monitor with amplitude integrated EEG or full EEG during the whole hypothermic course and for 48 hours afterwards. And then we need to think about what drugs to use to treat seizures, and effectively there are no drugs that have been effectively shown to stop seizures in newborn babies. There are very few trials. We all use either phenobarbital or benzodiazepine as first line. But actually, the evidence that they are of benefit is not there. In a trial of phenobarbital versus phenytoin from North America, only half of the babies stopped seizing. And actually, I suspect if you'd had a placebo group, half of those babies would have stopped seizing as well. So we have a real problem in treating seizures. So we always use an EEG. I think it's really important to do that. And I actually do think that you can use amplitude integrated EEG very effectively. You can use simple stick-on or needle electrodes, which is very quick and effective to place, and that gives you a window on what's happening to the brain. And I do think that 1 or 2 channel EEG is enough, though you must understand that if the seizures are happening here and you're monitoring from these 2 points on the brain, you may not see all of the seizures, but it certainly is enough to take your intensive care forward. The other thing that we discovered whilst trying to develop a new anti-seizure medication was that actually we're pretty awful at treating seizures. We think we're quite good at it, but these are the seizures that we recorded during this trial. We had 14 children, and this is the point at which the first drug was administered. And you can see that seizures come and go. They come and go, and they are quiescent. They may start again, and often we're giving drugs after the seizures has burnt themselves out. So effectively, we're giving them unnecessarily. And the natural history of seizures after intrapartum hypoxia is very much of rising to a crescendo and then fading away. So we do need to be very careful. And what I've been used to doing personally is using a continuous infusion of lidocaine, which you can only use if you haven't used phenytoin before, because of the cardiotoxicity. And we started immediately. We've actually identified seizures. But you can see in this study, which is from all over Europe, that often that drugs were being given to the child after the seizures had actually stopped. Personally, I think lidocaine is probably the most effective anti-seizure agent, but we are not allowed in the UK or in Europe to actually start treatment with lidocaine as a primary agent, and we almost all universally use phenobarbital. There are people who use newer drugs as they're coming along, but actually the evidence of their effect is very, very poor. And we're currently trying to trial levetiracetam and various other medications within a network that we've set up to try and study this, but they are challenging to study. In addition to the neurology, you need to pay very close attention to the child's homeostasis. Hemodynamic stability is really important, avoiding swings in blood pressure and perfusion. You may need to use inotropic support if necessary. You need to avoid low CO2s, avoid hypocarbia, because we know that actually may increase the insult and is related in itself to, within the trials, to a poor outcome. It also may reflect brainstem dysfunction, which is common in this area. And one of the problems with ventilating babies, as we do in my hospital, is that we actually often produce low CO2s, and then we have to take steps to actually let the CO2 rise. And also avoid hyperoxemia. We were treated yesterday to examples of the damage that hyperoxemia can cause, and I think it's really important because that may worsen the injury. Also, you must avoid hypo or hyperglycemia, which may worsen the injury. You need to normalize the magnesium concentrations, because magnesium is actually a fairly good neuroprotectant, but actually in the situations where you're cooling a baby, you must make sure that the magnesium concentrations are normal, because if they're low, it's a problem. You need to assess any collateral organ injury from the heart using cardiotroponin, liver and renal documentation. You also may be troubled with pulmonary hypertension during cooling, and if that's the case, often the only way of reversing that in a cooled baby is to reverse the cooling, and the pulmonary hypertension will generally resolve. You do have problems with bleeding, and you also need to remember that drugs take a long time to clear in a hypothermic situation. So I think that all this, as it comes together, means that we take a lot of care over the quality of the hypothermia that we deliver and the child's homeostasis during that first 4 days after birth. And I think that's really important and contributes to the better outcomes that we're seeing. The only specific complication I've seen is subcutaneous fat necrosis, which is a bit of a challenge and gave us quite a fright when we turned the baby over, as we had the baby on his back during ventilation, but this resolves usually without too much scarring. So choose the right babies, monitor closely and optimize your management, and also engage the parents during this time. It's very difficult if you take a newborn term baby and you render the child cold and unable to move because of your use of muscle relaxants. It is a real challenge, and the parents need to be carefully counseled through the process. We also now monitor using near-infrared as well, and we're learning a lot about the evolution of seizures and the evolution of brain injury with the combination of different modalities. So what other things can we use to try and improve the quality of outcome? Well, there's a whole series of interventions that have been proposed for this, and I'm going to talk to one or two of them as we go through. And there are a whole series of targets that we can use to actually develop new therapies to come forward and teach us a little bit more about what's going on in the brain at the same time. So we've looked at xenon as a gas. Now, xenon is a very expensive gas. It's also as the canisters that it comes in tell you, is an asphyxiant. And so you have to treat it very, very carefully. And you have to, if you're going to use xenon in clinical practice, you need some form of scavenging system. Otherwise, it's costing you a lot of money for 72 hours at something like $30 an hour to use it. We've trialed xenon, and we've not found it effective in a short-term study. But in the laboratory, it appeared to be quite effective, and we've now turned our attention to another one of the noble gases, argon. And argon appears to look at the appears to improve the scores in the laboratory of whole brain, thalamus, white matter. Absolutely much clearer results than we get with xenon. It improves the spectroscopy markers. You get faster recovery of the EEG with argon, and we can show decreased apoptosis, so that's secondary energy failure, and it's very promising. And of course, argon is much more plentiful than xenon and a lot cheaper. And so we're hopeful that we will start to see new trials with argon in the next couple of years. The other technique that we've also been studying is a very strange technique, and we hadn't really heard of it until we were talking to our adult cardiovascular colleagues. And they told us that if you have a heart attack or a stroke, and you put a blood pressure cuff around a limb, and you inflate it above arterial pressure for 5 minutes and then release it, and you keep doing this on a sequential basis, it actually reduces, through some humoral mechanism in the body, it actually reduces the extent of the damage after your heart attack or your stroke. We thought this was a bit of a joke, really, but actually when we started to do it, it's really fascinating. And it's obviously, like all of these interventions, it's much better if you can do it before the injury actually happens, but actually we can't predict when the injury is going to happen in birth asphyxia. And it promotes the endogenous release of autocoids. And we've started now to study that in the laboratory, and in our large animal model, it appears to be very effective. So not only will you be using noble gases to try and reduce the insult, you'll also be inflating and deflating blood pressure cuffs sequentially on the baby to try and enhance the body's autoprotective responses. The other drive that is going on at the moment is to find an intervention that you can use simply around the world. I think there's a lot of concern about the spread of hypothermia, particularly into undeveloped countries. And Nikki Robertson's trial in Uganda did show an excess of mortality in babies that were cooled. And that led us to stop developing that as an intervention within the sub-Saharan African setting. And part of that process, we believe, is that in those settings, infection is often a concomitant of asphyxia, and cooling babies who are infected actually is not very good, because you paralyze the body's response to infection, and the outcome is worsened. So we've been looking for simple, cheap interventions that we might be able to use, either in addition to hypothermia or as an alternative to hypothermia. And one of these is melatonin. Melatonin's a natural hormone. It's readily available. Anyone who's traveled will know. and it is a very good neuroprotectant. You can see this is the amplitude integrated EEG score, and you can see when you've used melatonin in addition to hypothermia that the EEG recovers a lot faster. You can see that in this situation where we're looking at different areas of the brain and looking at the evidence of apoptosis using a tunnel stain, you can see the blue melatonin group actually have much less brain injury. So we're actually looking to try and start that, and we have a proposal in at the moment with the funding agencies to see if we can start using melatonin both with and without cooling. The other thing that has become quite topical at the moment is the concept that you can promote brain repair after apoptosis by using drugs such as erythropoietin. And erythropoietin is a very potent anti-apoptotic agent, but it's also very much better at stimulating later stem cell repair. And there's a lot of evidence now that this is very beneficial. And in the laboratory, there's been an initial study within the human situation, and now there's a phase 2-3 trials are being run out of Germany. And I think this is a very promising way forward. There we go. So other approaches that you might take, in the Netherlands, they have tried to use treatment in labour when they think things are going wrong. And they've been trying to block the oxidative stress in labour by giving drugs to mother, allopurinol. These are very difficult studies to do, and it's very difficult to define which women to give it to, but they appear to be encouraging early findings. So we're trying all these novel therapies and trialing monotherapies to try and get us away from the cooling situation. And we need to understand that cooling is not an ideal intervention to use in low-income settings, where, of course, most of the asphyxia actually occurs. And it is an intensive care intervention, so we desperately need new interventions there. So in summary, I think over my career as a senior clinician, I've actually seen the whole area of asphyxia be transformed by the evolution and introduction of hypothermia. Still around the world, a large proportion of babies are dying because of asphyxia, and we need desperately to find the best interventions that can help ameliorate that. We need to be very careful when we're delivering hypothermia, and we've got a queue of new interventions to study, which should keep us in business for a long time. Thank you all very much indeed.
Thank you so much for your presentation. Can you tell me, please, do you have experience using melatonin? I'm interested in some preliminary scheme. To whom, when? Do you have IV or IM, intramuscular melatonin, or use just the oral melatonin? Thank you.
So the question is around melatonin, and I mean, the attractiveness of melatonin is that it is very easily absorbed, and therefore you could theoretically use an oral preparation. We haven't used it in as a treatment yet because we're still trying to get the regulatory system sorted out so we can run a trial. But in the animal situation, we've been using intravenous preparation, which is, of course, runs the risk of the company that prepares it making it very expensive, whereas the reason for using it is it's very cheap and could be used around the world. So that's where we are with melatonin at the moment. I mean, I'm hopeful that we will be able to get it into practice in around about 5 years. But, you know, the regulatory studies do take a lot of time. Yeah, thank you.
Thank you very much for your very excellent, very
great,
brilliant
lovely,
presentations. It's very nice. I have a few questions for you.
Yeah.
First of all, let's start, okay? Let me introduce case number 1. We have some very sick patients, low abdominal score, it's very severe neurodevelopment or very severe neurologic signs, okay? And we started cooling. And after 24 hours, we observed laboratories and we observed very high leukocytes, positive bacterial culture, and we suspected infection disease in this baby. And this baby have hypoxic, very hypoxic ischemic severe encephalopathy and plus infections. What you recommended to do? You need to stop hypothermia and provide it cooling for 72 hours.
Right. I mean, I think one needs to monitor very closely for infection in those situations. And I think if the child is becoming sicker despite your treatments, then we would generally stop hypothermia. We're not wedded to delivering it for 72 hours because we understand the dangers of doing it. I think there's also another danger with hypothermia that because you cool somebody, and particularly the way we do it with ventilation and muscle relaxants, you don't necessarily assess the baby as you would have done in days gone by. And there is a serious danger that you might be treating children who are going to go on to have very severe disability and die over the first year with a quadriplegic cerebral palsy. And I do think it's important that you continually assess the child and assess whether your treatment is the right thing to do. And we actually quite often stop at 24 hours. We then will do an MRI, and we will look at the baby's brain, and then we will usually offer the parents the opportunity to discontinue intensive care.
Maybe Nico Robertson answered for another way because he used melatonin and melatonin infections and hypoxic ischemic encephalopathy, and it's a very nice idea to use and combine these strategies. Okay, another case, if accidentally we have suspicions about intracranial hemorrhage. The first questions, but we don't have in any departments in MRI diagnostic in the first hours. In the first 24 hours, in the first 72 hours, it's very difficult to provide like these investigations. And first questions about intracranial, and another questions about intracerebellum hemorrhage.
Sorry, what was that?
Cerebellum. Cerebellum hemorrhage. It's not contradict. It's no one paper about intracerebellum hemorrhage.
I mean, we do probably too many ultrasound scans after birth. Ultrasound's not the best way of picking things up, but we do use ultrasound to look at the Doppler as well in the circulation, because that gives us a good prognostic marker as well, which is simple to do at the bedside. And that will tell us whether we need to go on and think very much harder about whether we should continue the cooling therapy. So I think the point about hypothermia is that we need to use every potential way of looking at the baby to tell us what's going on.
Thank you. Next questions. In 2017, Marianne Theresian issued a very interesting article in Pediatrics. And this issue about cooling and the outcome in babies undergoing 6 years. And in these investigations, Marianne Theresian investigation during therapeutic window, and she started cooling babies 3 hours, and compare with the babies, she started cooling 6 hours, and the outcome of this issue, this investigation is very nice, because neurologic outcome of the baby who are undergoing cooling in 1 to the 3 hours is more better. Can you edit some comment for these situations?
Yeah, well, we now usually start within an hour of birth.
Oh, it's very nice.
Yeah, I mean, if it happens in our hospital, and actually we have protocols because all our hospitals at home are networked together, So if you work in a small hospital, you will have available to you all the protocols that everybody uses. And we have a rapid transfer team that can get there. And distances in the UK are nothing like as large as they are in Ukraine. So we do tend to start very early now. And it's quite interesting. I until the summer, I was doing a lot of the follow-up for these babies that have been cooled. And, you know, we have very few children who have severe cerebral palsy now.
Oh.
In my hospital. But I know in other parts of the country they have a lot of cerebral palsy. And I do think it's because we pay special attention to making sure the hypothermia is delivered properly, and also we evaluate the child early on.
In my hospital, the situation is the same. It's, let's go to another questions. Okay, let's talk about CPR. If you provided CPR, cardiopulmonary reanimations, what you recommended to our audience? You should, you're thinking this baby is undergoing hypothermia, yes?
So
when we started provide cardiopulmonary reanimation in delivery room, yes? And this baby, in my opinion, during the last 3 years, undergoing hypothermia.
Yeah.
What you recommended keeping cool this baby during reanimation, on keeping warm.
Yeah.
It's very difficult. It's for me questions. What can you edit some comments?
I think it's a really difficult one. I really, I used to get very angry when the doctors attending a reanimation would cool the baby down before it got to the ward and switch everything off. Occasionally you can predict that's what's happened. If you've got a clear sentinel event, you know, cord prolapse, and the child's in poor condition at birth and you've got to ventilate the baby, then I think that's probably allowable. But actually I want to assess the child carefully before we start hypothermia. And the moment you cool somebody, certainly in our setting, you can't assess the child neurologically because you're using muscle relaxants. So actually one needs to be very careful before you embark on that. Yeah.
Yeah, thank you. In your presentation, you pointed out that rewarming, it's very local renosis resistance. These babies. In my skills, we're undergoing 100 babies during the last 10 years. Rewarming, it's a very, very important question because we started 0.1 degrees in 1 hour. Because it's very many seizures can occur during rewarming. It's very best. You needed to notice about this. Yeah. Okay, what do you say about lidocaine? Lidocaine, can you occur some side effects when you're using side effect lidocaine prescriptions?
Phenytoin.
Okay.
I mean phenytoin.
No phenytoin, lidocaine.
Oh, lidocaine, yeah.
Okay, lidocaine side effects. I mean side effects can occur in your practice.
When we first started using lidocaine, we didn't really know how to use it from a pharmacokinetic perspective. The group in Utrecht, led by Linda de Vries, has undertaken some really good pharmacokinetic studies. And we now have a standard protocol where you automatically reduce the dose of lidocaine over a period of about 24 to 48 hours. By using this, we've never had any significant side effects. But I do know when people started using it first in the early 90s, that they had a lot of problems with cardiac arrhythmias, which of course is the big danger. It's also important to know that, you know, during hypothermia, the excretion of lidocaine is much reduced, and so you actually have to use lower doses. And you have to use it for less time. If you look, I can send you the references if you want, because I think it's been an excellent anticonvulsant, and we've been trying to get it trialed on a European basis, but it's quite difficult to find the money because it's an orphan drug, effectively.
In my department, we use the same situations, the same anti-seizure treatments. And what do you say about levetiracetam? Levetiracetam.
Oh yeah.
We use the next step after phenobarbital is falling down. Can you add some comments?
I have no experience with this at all.
No experience at all, yeah?
Because I actually won't use a lot of these drugs unless I've actually got evidence that they work. And we know that treating newborn seizures is different from treating seizures in older children. The whole mechanism of seizure production in the newborn is different. That's a completely different talk. It takes a long time to go through it. But so I tend to stick to very simple, straightforward anti-seizure medications. Phenobarbital, lidocaine, and occasionally have to go to midazolam.
Okay.
Yeah.
In your presentation, you showed that you use AG. You use one channel, two channel AG.
Well, actually, we, because we're interested in monitoring, we use a full array of EEG in our practice. We tend to use two-channel AEGs in the rest of the network because they're simple to put on, but we have a on-call EEG technician who comes and puts the array on for you. So it's we have the benefit of full EEG and multi-channel AEG displayed at the same time, plus an automatic device that tells us when the child's seizing, which is actually quite useful.
Thank you for your answer for my questions. Maybe in the future we use cocktail therapy in hypoxic ischemic. And thank you very much.
Yeah. When I was first interviewed as a consultant in Bristol, I told them we were going to need a cocktail, and it's looking that way as well. Yeah.
Thank you very much. A very relevant topic. Usually hypothermia is started before 6 hours of birth, so they start hypothermia. In some US centers have protocols talk about up to 12 hours period, and probably that's important for Ukraine because we have large distances in case a baby needs transportation. What do you think about that liberal period of 12 hours?
The question is whether we should start it a bit later in situations where the transport. I think the answer is yes. I mean, I think we take each child on its merits as he comes in. It is quite possible to cool the child during transport, and it is quite feasible to get the cooling started before the child leaves the district hospital, and even in our very small special care baby units around the country, we can usually start the process before they leave. So it does shorten the time.
Thank you. Second question, what is better, cool cap or total hypothermia?
Sorry, say that again. Cool cap. Oh, right, yeah.
Yeah, cool cap.
Oh, yeah. Well, yeah. It's always seemed a bit strange to me to put a cool cap on and then heat the bottom end of the child to actually keep the rest of the body warm. I think whole body hypothermia is much more effective. It's also interesting that in the Toby study, Toby is the only study that has actually followed children up to school age and shown benefit in terms of cognitive outcomes. And we used the Tecotherm cooling mattress, and now we use the little cooling suit. The cool cap study has never really properly been followed up. And the NICDHD study did show improved outcomes at 6 years. But if you actually look at the paper, you see that actually the outcome that is improved is death. So they have reduced death in the cooled groups, and that's still the same at follow-up. So that's why it looks as if it's beneficial at 6 years. But they weren't able to show any benefit on cognitive testing. We were, and we did it very carefully because it's very interesting. Yeah. Hi.
Thank you so much for your interesting presentation, and the number of questions shows that it really was really interesting. My question is as follows. During hypothermia, or should we put it this way, what are the indications to hypothermia? And for that, do you use only the EEG data, or maybe as a simple lab marker the cell death? Say, for example, increase in aminotransferases levels. Do you use that maybe? Or, for example, the signs of reduced glucose utilization. Do you use that? That's question number one. And question number two, right away. Do you use proteolytic enzyme inhibitors like protease inhibitors to prevent the cascade cytolytic mechanism like lysosomal mechanisms as a, for example, cytoprotectors or neuroprotectors? Thank you.
Yeah, thank you. The first thing is that, as I indicated, asphyxia also hits the other body organs. But we're focused on the brain, so we actually have that three-stage process. We need evidence of something happening immediately prior to birth, so the child's in poor condition. We need abnormal neurology, so we do a careful neurological examination, and then we use the AEG. Now, some of our smaller centres will not have an AEG, and we allow them to cool and while they send them in, but we would then, if the AEG was normal when the baby arrived at our unit, we would consider stopping the hypothermia. So we use brain-oriented markers to drive our cooling. We also, it is actually very important to look at liver and heart in particular and other organ systems. Many of these cases in our country and in many other countries come to litigation, and actually finding evidence of asphyxia in other organs is a key factor in showing that you were right in your treatment. So I think that's really important. Serological markers are very much more difficult, and there aren't any good serological markers that you can use. There is a biomarker study going on in Germany at the moment called BANON, and they're looking to develop a panel of metabolomic measures that will actually tell you how severe the child is at the start of treatment. And if that comes to fruition, that should be very valuable. But we really don't have any other things open to us. The other thing is that hypothermia is very good at shutting down the inflammatory cascade. That's why if you're infected, actually the infection often gets a hold during hypothermia. So we are actually addressing that, but of course we wouldn't be allowed to use them unless we had evidence they were beneficial. And every time people have tried to study them, it's not really been proven that they are adding significantly to what hypothermia does. It's very difficult to study new drugs now because hypothermia is quite effective, it's ingrained in the system, and so we have to look at hypothermia with something else. We would find it very difficult to get in our setting a study through which didn't include hypothermia. So, you know, it is challenging, but we have settings in which we can do monotherapy trials, and hopefully they will come to fruition in the next few years. Yeah, thank you.
Hello, I have a question with regards to hypothermia and intracerebral bleeding. Sometimes it's a severe condition of a baby during the first hours is due to intracranial bleeding. Would that be an indication to hypothermia, or should we do hypothermia even if we have suspicion of intracranial bleeding? Thank you.
I think if you've assessed the child and you've got good evidence for a significant intracranial bleed, I would stop the hypothermia because we know that it will just encourage further bleeding. So I certainly wouldn't call somebody who's had a major intracranial bleed because A, it may worsen it, and B, there's no evidence that doing that. It's not like a situation stroke. And we've looked at neonatal stroke as well to see if that would be a reasonable indication for cooling, but it's such a difficult area to study that we haven't come to a conclusion, and we do not use hypothermia when we've identified a neonatal stroke. So we keep away from that. Yeah, thank you.
In your presentation, I actually got one question. During hypothermia, in case of severe asphyxia, quite an often problem would be hyperglycemia, and if you, what would be that figures when you do that?
Hyperglycemia is an interesting situation. That was the question, wasn't it? Yeah.
Hyperglycemia.
Hyperglycemia. Yeah. That's what I was talking about. In the early trials of resuscitation done by Jeffrey Dawes and colleagues, they used a bicarbonate and a strong sugar solution as part of their resuscitation to try and reduce the acidosis and provide glucose for the cells. I think there is limited evidence on whether hyperglycemia is actually beneficial in that situation. And I do think it is best to just keep the blood sugar as tightly within the normal range as you can. Yeah.
Thank you very much for your presentation. Let me reiterate some pieces of information, though you had it on the slides. The late preterms, do we have to cool them or no?
No. I think anyone below 36 weeks, we do not cool. I mean, 35 weeks and 4 days, 5 days, we think about it. If there is a sentinel event, so if there was a cord prolapse and clear evidence, we might do that. But below that, no. Yeah. Sorry. Yeah.
Maybe I misinterpreted myself. What figures of severe hyperglycemia? When will you use insulin?
Ah, right. Sorry. Yeah. I apologize. Well, we tend to reduce the glucose load to start with, and then we, if the blood sugar is above, I think we use 12 millimoles per liter, we would then start to think about using insulin. But we very rarely have to use insulin in this particular patient group. We just manage it with the glucose infusion.